Hello. Good afternoon, everyone, and welcome. My name is Tiziana Rivera. I'm the Executive Vice President for Quality Research and Chief Nursing Executive. Thank you so much for joining us this afternoon. And it's my privilege to introduce today's speaker for what promises to be an enlightening and inspiring presentation titled Stepping Up for Health and Wellness. Our presenter, Dr. Michael O'Leary, is a distinguished leader, educator, and researcher in the field of health and wellness. With a career spanning more than a decade in Ontario's post-secondary education system, Dr. O'Leary has been shaping minds and strategies for the expertise and vision for the future. Since 2017, he has been serving as the Executive Dean of the Faculty of Applied Health and Community Studies at Sheridan College. In addition to his role as Dean, Dr. O'Leary is the institutional lead for Sheridan's integrated health strategy, where he has been at the forefront of advancing student engagement and strategic planning initiatives to promote holistic health and wellness across the institution. Dr. O'Leary's research background is equally impressive. A specialist in muscle adaptation, he has contributed significantly to the field through several peer-reviewed publications. His academic and professional journey includes pivotal leadership roles at Humber College and the University of Guelph-Humber, further solidifying his reputation as an innovative educator and leader. Today, Dr. O'Leary will take us on a journey of discovery as he explores strategies and practices for stepping up to better health and wellness, not only as individuals, but also within our communities and institutions. So please join me in welcoming Dr. Michael O'Leary to the stage.
Thank you, Tatiana. Thank you very much. Good morning, good afternoon, everyone. As was mentioned, I'm the Dean at Sheridan College. It's my pleasure to be here today to talk to you a little bit about upstream care, preventative care, which is something that's on the forefront of our minds at Sheridan College, and sort of how we are hoping to complement the complex care needs of individuals now and in the future. So just to begin, the top right-hand corner for you is a image of a Time magazine that really was impactful to me. In 2006, 2007, our Supersized Kids came out, and it talked about, for one of the first times, the diabetes belt. And if you can see the map of the American country there, you can see that the diabetes belt extends up from Louisiana all the way up now into Pennsylvania. And is really a growing problem, pun intended. In Canada, we see a similar result as time goes on. We see an increasing in the amount of red in the Canadian country. And so what we're going to focus on today is really setting the table around health and wellness, where we currently sit, talking about a little bit about a theory or observation about how health and wellness proceed, then moving into some of the near and dear components of what's going on in Peel region and in Brampton, and then where Sheridan sees itself in the upstream care environment. So this is probably influenced by my heritage, the Shamrock sort of view of this. But what we're really looking at here, and people have challenged me on this before, around the major factors influencing metabolic disease and chronic disease. This is not every factor. This is not all the complexities in it. But certainly when we talk about the stem there being chronic disease, and the three leaves that are really feeding some of the incidences of chronic disease, obesity and overweight. We know that adipose tissue or fat is not an inert tissue. It actually is a active signaling tissue in our body that can really exacerbate the progress of diseases like type 2 diabetes, cardiovascular disease, etc. Being physically inactive. When we are physically active, our muscle, lights up with a signaling array that promotes health. It helps to regulate blood glucose. It helps to offset resting blood glucose rates. The progression and development of muscle over the lifespan also maintains healthy body. Now, when we lose that muscle mass, it again accelerates that condition of chronic disease that we see there. Finally, nutrition and processed foods. As we've seen over the last certainly 2 decades, but beyond that, the amount of food processing and the amount of food chemicals going into our food are now deeply affecting children that are going to grow up into an environment where processed foods and the chemicals in those foods will exacerbate, again, the diseases of chronicity listed there. So depression, hypertension, cancers, heart disease, type 2 diabetes all fall into this category, but also there's many, many more. And so we're going to first look at obesity and overweight in Canada, move on to physical activity, and then foods. And then we'll move into the region of Peel, and then finally Sheridan College. So just clinically, I recognize from the beginning, I get it, that BMI is not always the best assessment of a clinical diagnosis of obesity. If you're an athlete, you're 6'2", you're 250 pounds, you're in great shape, 4% body fat, we wouldn't obviously see you as obese, but the clinical definition would. That aside, we typically use BMI above 30 as a sort of entry level into what is obese. And then there are subclassifications within obesity that we'll talk about. So we'll begin with some historical data. You can see here, Canada and the US, similarly colored in blue, with obesity rates that are near and around the 60%, obesity and overweight individuals, approximately 60% of the population. On the graph, you'll note that there's a linear sort of progression from 1975 to 2016. Now, currently in 2023, we know that there are 9 million adults who are obese, with another 11 million adults who are overweight. That is concerning from a healthcare standpoint, that is concerning from an individual standpoint, that having more and more individuals fall into these categories places a downward strain, obviously, on the work that's here done at William Osler, but also across the healthcare units that we will leverage. But what's more concerning, I would say, is the progression. And so looking at, hopefully you can see the graph there. I'm not sure if you can you? Nope. Let me see. It's not coming up. There it is. If you look at the graph here, on the x-axis, you can see time, you see the years, and on the y-axis, you can see percentages. And what you'll note is that over time, the dark blue bar is getting slightly bigger. It's going from about 26% to about 30%. That represents the number of individuals who are obese. And so what we're seeing is an increase year over year in the number of individuals who are classified as quote unquote obese. But what's not changing is the individuals in the blue bar, which is those who are overweight. So as more people transition from overweight to obese, there are people who are replacing those individuals on the overweight list. And so the delta between obese and overweight, if you look at the first set of bars, the difference between the dark blue and the light blue bar, and then if you look at the last two, you'll see that they're getting closer. And so the question becomes, what happens when the dark blue bar is bigger than the light blue bar, and we continue to progress and restoring and sort of not seeing a decrease in those individuals that are overweight? What happens to our healthcare system? What happens to the frontline responders? What happens to our doctors' offices? What happens to the solutions for that complex care? So if we were to take out, and again, what's very interesting is that if we take out individuals who are overweight, again, reiterating here, we're seeing Canada and US, as well as Mexico, the obesity trends, and you can see that Canada is slightly better than the US. But if you look since 1975, and you remember back to that first slide that we had, where we're looking at the individuals who are overweight and obese, the slope of this line graph is much steeper. I mean, we're seeing more individuals fall into that obese category faster. And so one of the things that is becoming more aware is that you spend a smaller amount of time in the overweight category and you transition into the obese category very quickly. And that becomes a real point of consideration when we talk about population health and we talk about what can we do upstream. What can we do before individuals are in an obese state? What can we do when they're prior to becoming overweight? What can we do in the schools? Of concern in the obese group, and I mentioned there were subclassifications at the beginning. Again, on the right-hand side, the line graph, I just want to orient you to the purple line and the green line. And you'll note that those are the fastest growing groups over this time period. The purple line is the class 3 of obesity. It's a severely obese individual. And the green line is the class 2. And so within the obese group, the fastest growing groups are those that are associated with the highest health risks. And so not only do we have an increase in obesity, we have actually an increase in those who are transitioning through the obese categories. And in the purple group, that's a 455% increase over that time period. Nationally, you can see to the left, the bar graphs, you can observe sort of where we sit in Ontario. We're sort of the middle towards the bottom end of the provinces, with the maritime provinces sort of sitting on the higher end. And to give you a better perspective of the maritime provinces, I'll just show you this graph, which details, from mostly the maritime provinces and Saskatchewan all the way down to British Columbia. And you'll note that we range from about 30% to about 40% individuals who are obese by province. So this is the adult group, and it's a fairly good classifications based on health data. What happens in our kids, or what is happening in our kids? Again, this data is from 2016, so you might imagine it's a little bit more, and we'll look at some more recent data in a second. But what you can see is that in comparison to our closest neighbors, we're slightly better, but we have 8.6% of children and adolescents from 6 to 17 years old in this time frame classified as obese. What's shocking is during this time, 6.3% of children 2 to 5 are obese. And you can see the growth of obesity in children has been increasing. And a recent calculation puts it that obesity rates in children have nearly tripled in the last 3 years. So as a society, if we take this holistic lens and we say, okay, over the last 40 or so years, we've been seeing increases in obesity in our adult group. And that's been associated with increases in things like type 2 diabetes, which is a very complex thing to manage, but we also know that we can manage it really well, but we're going to be managing it for a number of years. Places a strain on our healthcare system. Now what happens when the children who are obese become adults? What happens to the rates and incidence of diabetes, cardiovascular disease, cancers? And what is it that we can do differently in order to support the health and wellness of our society and certainly our children? This is a better look, a more recent look. I shouldn't say better. It's a more recent look from obesity trends. And again, it's much like the graph from before, where you see obesity is increasing. There's a small decline there in 2017, 2018, 2019, but then it shoots right back up. And if you were to draw a line of best fit, it would look a lot like the previous graph. So our kids are now becoming, or more so are becoming classified into the obese category. We look at the physical activity data, I think there will be some interesting parallels to it. But if we were to go back to that shamrock example and think about that one leaf, and we can literally say that leaf is becoming more prominent, obesity is becoming more of an issue. The adipose tissue, we know it's not an inert tissue, it is a signaling tissue, and it would therefore be contributing to an increased incidence in chronic disease. And in the future, it's going to get bigger. If we were to shift our focus now to physical activity, this is near and dear to my heart. I'm an exercise scientist. I did 3 degrees in kinesiology. I looked at the molecular mechanisms of muscle. And for my entire lifetime, we have been reporting that there's been less and less physical activity. With the introduction of screen time and it being more accessible, that has just gotten worse. And so 49% of adults age 18 years or older are getting the 150 minutes of moderate to vigorous activity. And I just want to emphasize the 150 minutes of moderate to vigorous. Only 50%, 1 in 2. 29% of children and youth between the ages of 2 and 17 achieve the national guidelines of 60 minutes of moderate to vigorous physical activity. And so when we think about that conundrum, that the children are not getting the exercise that they need. Adults and youth, however, spend approximately 9.6 and 8.4 hours respectively being sedentary. I think we can all identify with this in terms of the jobs that we may or may not work, if they're behind a desk or not. But outside of that, when we're actually sitting down at home, when we're watching TV, when we're getting some leisure time, what does that look like? And so what may be happening is when you go to your child's activity, instead of going for a walk, you're bringing the iPad and you're watching and you're sitting down. And so again, if we look at levels of physical inactivity and what that's doing to our muscle composition, less muscle means a more active blood glucose level, most likely. And we can see that that can aid the progression of chronic diseases like type 2 diabetes. If we look at sedentary behavior, this comes from a report from FAHCS. It was a really poignant report. I won't read all of them, but 56% of adults aged 18 to are spending less than 3 hours of getting less than 3 hours of light physical activity per day. 12% of adults 18 to 79 achieve or less than 1 hour. Greater than 8 hours of sedentary behavior per day. So we're sitting more, we're exercising less. Again, when we think about what this does to our children, and we're looking at the results with children, we have to understand that it's going to be a lifelong effect for them. It's going to impact them over the entire lifespan. And there's one critical piece of data that's coming up in the next slide that I want to orient you with, but 47% of adults with one or more chronic disease are achieve at least 150 minutes of that physical activity, whereas 56% of adults without. So if you have a chronic disease, you're actually moving less than those who don't. And that may be part of the chronic disease. There could be more investigation there, but you actually might need that exercise even more than the healthy individuals. If you look at the guidelines, we often use 10,000 steps as a guide for the day. In this particular thing, they use 7,500 steps. And you can see the same relationship. 47% of those with a chronic disease are getting those steps, whereas 57%, 10% more without a chronic disease are achieving that. So again, a conundrum that we're facing with respect to our populations with diseases of chronicity already. Activity in children, we look at the activity in children. The one that strikes me the most, 4% of children and youth, 5 to 17 years old, are able to meet the 24-hour movement guidelines set forth by the Canadian guidelines. So 4% are meeting the 24-hour movement guidelines. So what challenge do these data present? Well, a recent study, how sedentary are Canadians, it depends on how you measure it. It showed that Canadians will over-report the exercise that they get and under-report the sedentary behaviors they engage in. That's not shocking. And so they used an accelerometer to actually compare the self-report. What is shocking is that all of the data that we have talked about here in relation to physical activity, much of it is self-reported data. So what I'm trying to say is that the numbers you see here for exercise, that's the absolute ceiling that we're getting, because it's most likely much less than that. And the numbers that you're seeing here, which are very high for sedentary behavior, that's likely the basement of where we're at, and it's actually much higher. And so that, compared with our body composition being more overweight, more obese, creates that second leaf. We're not getting as much physical activity as we used to. We're not activating those muscle pathways. We're not activating vasodilation pathways. And we're seeing the effects of that now in our children. Let's talk about food. So when we talk about food, you can see here, I've sort of mapped out this scatter plot of 100 countries, I believe. And you can see the Canadian line there in orange, and you'll note that we moved from, just under 3,000 calories in 1975 up to about 3,500 or just under 3,500 calories in 2016 per person. Now, there is a bit of a poverty paradigm that we're going to talk about here. So in Canada, if you're on the lower end of the socioeconomic status, you're actually more likely to be obese, eat more processed foods, etc. And so you're likely to have a diet that's more calorically dense in fat, sugars, etc. If you were to map out a emerging country or a first world country, if you were poor in the emerging country, you would actually be much lower in your calories and you'd be much more likely to not be obese. And sort of a poverty paradigm in the sense that in an emerging country, you might be starving and that's really bad and we have to do something about that. But you're not going to suffer from diseases of chronicity your whole life, likely. Other than, a genetic exception, but you're not going to suffer from the metabolic diseases that we've been talking about. However, in a first world country like Canada, US, if you're on the lower end of the socioeconomic status, you are more likely to suffer from those diseases. You'll be more likely to be sick, but you'll be well fed. And so a lab out of U of T published this great infographic, and the quote comes from their lab. But what it shows here is that little or no processed foods, are those meat, the chicken, those types of items that they display there, the fish, that are relatively healthy when they're part of a total diet that includes fruits and vegetables. As you move down there, you get more and more to the ultra processed foods. And the ultra processed foods have grown and grown and grown in our society, and they have become more prevalent. And so what we may have eaten as children, I can remember being a child in Canada, there wasn't a McDonald's on every corner like there is today. There wasn't a Tim Hortons around every corner like there is today. And so there's much less exposure to processed foods. Even in the grocery store, there were less options for processed foods. Now today, absolutely, there's Walmart, there's many more McDonald's, there's many more Tim Hortons, et cetera, and there's many more brands of that. And what we're seeing is that in Western countries, about 75% of the food supply comes from packaged processed food items. 75%. In that, ultra-processed, ready-to-consume foods, which are typically energy-dense with high fat, sugar, and sodium content. Some of these are out of convenience and some of these are out of necessity based on your lifestyle. And I'll talk a little bit about that when we talk about the work that we're doing at Sheridan College. So let's talk about some friends, or not some friends, of individuals that are in our food. And by individuals, I mean petroleum products. So I'm going to begin with a bag of Doritos. It has tartrazine, or yellow dye number 5 in it. It is a petroleum product. It was initially used in coloring our clothes in materials. And one day someone said, hey, it'd be great if we added that yellow dye number 5 to make this nacho cheese not red, and it should look yellow. And so they have been using it to make our food look a certain way. And it has been linked to things like asthma, ADHD, cancer, food intolerances, and many, many more. And what the theory behind it is, it can only be in 300 parts per million per product. So you can only have 300 parts per million max in your Doritos, and that's it. What they haven't really studied is the combination of chemicals that they've allowed us to put in our food. The other one is Sunset Yellow there, FCF, another petroleum product linked to many of the same conditions, also in Doritos. And then Allure Red. Allure Red, as you can see there, linked to a number of different health challenges, nausea, headache, etc. But now they're all in combination. But what happens when our food becomes from lightly processed to ultra processed? Well, now in a current day, and I'm picking on a few here, but there are many. Now in a current day, you might have multiple foods, often foods that are geared towards children, that have tartrazine, that have brilliant blue, which I haven't mentioned, that have yellow dye number 5, that have FCF Sunset Yellow. And so when we think about that shamrock again, we're looking at an increase in the obesity leaf, an increase in the physical inactivity leaf, and an increase in the amount of processed foods, or decline in our holistic nutrition, all which are feeding a chronic disease epidemic that is inclusive of type 2 diabetes, heart disease, cancer, hypertension, depression. What I haven't talked about is the ring around the actual shamrock. And that ring represents all of the other malleable factors, which play a huge role in determining individuals' exposure to the sort of the leaves on the shamrock. And so what I'll briefly talk about here are the malleable factors influencing health outcomes, also called the social determinants of health. So your educational status, the safety of your community, your access to healthcare, all of those social determinants play a role in how you're able to navigate this new world of processed food, how you're able to navigate this new world that's built for sedentary lifestyle, and how you're able to navigate perhaps some of your genetics, which we often don't get to choose. In fact, we don't. On the right-hand side there, the factors affecting health and wellness, and it says premature death, but in the center is health and wellness. You'll note that about 50% falls into healthcare or our own personal behaviors. So we have a locus of control. We have an ability, but another 20% there represents the policy decisions that we make, the communities that we build, the academic and health institutions that we lead that can have a real impact. And if you put those together, they represent a vast majority of the things that we can do outside of our genetics. And I do think we will talk about genetics in a moment, because it is vital that the region of Peel is highlighted in this way, because there's a disproportionate effect of genetics in things like type 2 diabetes here. So that brings us to Sheridan's Center for Health Innovation and Community Wellness. We're currently in the process of working with the city, and the city of Brampton's been fantastic to help us build a new building that is community focused on upstream preventative care. A famous sociologist once told the story of, you're walking down a stream and you see someone drowning in the river, you jump in and save that person, you get them back to shore, and then you see another person drowning and you go out and you save them, and then and then there's another person, and you go and save them and another person. You never actually get to the point of going up the stream to find the bridge that's broken, that's causing everyone to fall in the river. And that's what we see our space. We know that more hospitals need to be built, and William Osler's done a fantastic job in advocating for this region, and they're well underway in getting a new hospital built, and that's amazing. We do know that we need more medical doctors, and TMU as well as York are going to be building new medical schools, and we absolutely need them. Where we're focused is the upstream preventative care that works in collaboration with a physician, and some of the reasons why we need to be there. So in Peel, 58% of individuals are physically inactive. 58%, more than 1 in 2. 1 in 2 individuals have at least one disease of chronicity. And when we think about the region and how it's growing in population and some of the stresses that place on institutions like William Osler, that's substantive. 73% are individuals who are new Canadians and, who are individuals who do not have access to culturally competent care. So language, when you're talking about educating individuals about how they're going to manage diabetes, language barrier might be really important to navigate, might be vital to make sure that that individual is able to be successful. Importantly, 20% South Asians have been shown to develop culturally and genetically diabetes at 20% lower body weights. So we've just spent all this time talking about obesity and weight, but there are genetic predispositions that make people more sensitive to seeing a progression of chronic disease within their community. And certainly we've seen that in the South Asian population. I actually was speaking with a South Asian doctor recently, and he said in his clinical practice, he treats every South Asian patient as a diabetic until proven otherwise. And that is something that is reverberated with me as we progress through this work. This last number is a little dated because they came out with new numbers that we know we're going to be short more than 37,000 nurses. And if you add PSWs into that, which help move along the healthcare system, certainly in long-term care, we are short nearly 100,000 individuals by the year 2030. So why is the focus for us in at Sheridan sort of on the diabetes lens? Well, this is data from Ontario Ontario Health, and the ministry published sort of this interactive map that can leverage, shows the prevalence of diabetes in adults in Peel Region. And you can see, unfortunately, Peel Region is well ahead of everyone in terms of prevalence of diabetes, and it's graphed there below. But the incidence of diabetes, the new cases of diabetes each year, Peel Region is just destroying the rest of the competition. And that's not a good thing, but it is a reality. And what I've done below there on the right-hand side, you'll note, is that I've graphed Peel Region. You can see Peel Region's sort of incidence of diabetes, and below it is Brant County. Brant County is the second on that list. And it shows you how much higher Peel Region is in developing the incidence of diabetes. And so Sheridan College, we're looking to be, we have 20 academic programs that are spanning across 5 different schools: School of Nursing, Education, School of Community Studies, School of Applied Health, and School of Public Safety. And across those different schools, you might wonder, well, there is a level of continuity. You're not healthy if you're not safe in your community. And there's a working group within Peel Region working on community safety, in fact. And so our School of Public Safety plays an important role in that regard. And our School of Health and our School of Education can all play a role. But what really makes the center that we intend to build a very unique space is the building will have academic spaces, it'll have learning spaces for our students, but it will have a ground floor clinic focused on upstream preventative care. And I want to just give you an example. If we have an individual referred to us through partnerships who has type 2 diabetes, she comes in and is seen by our team. Maybe, you know, as I mentioned again, as an exercise scientist, we've been telling people to exercise more, and it has not been a winning message. But this individual comes in and says, hey, my health is a priority, but listen, I have young kids. They come home, they need to eat, they have activities, they have homework. I also have elder parents, and we're navigating the healthcare system right now with them. I don't have space in my life to navigate more exercise because I'm just burdened with all my responsibilities in life. This is not an unusual story. And so what we foresee our ability is for us to create space for that individual. We have ECs that are well-trained, that can supervise kids, they can help get some of that homework done. We have social service worker students who are expert system navigators that can help them navigate the system and potentially reduce the amount of time that they're spending, you know, finding the right advocacy point. Then we can begin to open up space for, hey, let's talk about the education around diabetes. Let's talk about an exercise plan. Let's talk about that hip that's been hurting you and preventing you from exercising, giving you some rehabilitative services. Let's put you on our anti-gravity treadmill so we can get you moving during that time where your hip is really immobile. And so you're not sitting around and, you know, seeing the disease compound itself. Now that is a powerful piece that we want to begin with. But when you pair that with the advances in artificial intelligence, biometrics, et cetera, we can really begin to provide more personalized upstream care. And so you might think that if you get 15 minutes, 20 minutes with your GP a month, you're a superstar. That might be every 3 months, might be every 2 months, but it's a limited amount of time. If we in the center get 2 hours a week with one individual, that's fantastic, but there's still 166 more hours in the week that we don't know what's going on. How are they sleeping? What are they doing? How are they moving, eating? So that's where biometrics comes in. And we hope to look at especially culturally competent care, but also to do research on that culturally competent care based under systemic factors like biometrics. Let's look at how much they're moving, how much they're sleeping. Let's look at their blood glucose levels throughout the day. Where are we seeing the spikes? Where are we seeing the lows? And so on the right-hand side there's a unique image. I asked AI to show me a picture of biometrics. And so this is what came out. There's some super watches there that apparently are coming our way. But nonetheless, you get the idea that, you know, where we sit today is we have a growing problem with our trends in physical inactivity, obesity, and the foods that we have access to in our eating. We need to take a different approach that works upstream of the care to prevent individuals from having to use our primary health care in acute conditions. There are a number of stats that could be thrown out, but ultimately what we're looking to do is begin that upstream care research to develop those best practice guidelines where we can determine when someone might be in that sort of dangerous zone, like we do with a pre-diabetic, in terms of prior to becoming a pre-diabetic. And so when we get there and we work with a team across a whole different group of allied health professions, as well as our primary care professions in nursing and with physician recommendations, we can see a building like this contribute significantly to the health and wellness of the local citizens in Brampton and Peel region. Thank you very much.
Thank you, Michael, for really showing us and sharing some really powerful statistics. I don't know if I'm depressed or inspired, but I think about the number of hours of inactivity, and I think about that in my own work. And we joke about it. We think we do because we know that we're sitting down a lot of times and we think standing is going to help. It doesn't help. We actually have to move. And so I'm just thinking, we do have some questions that came over because we have people online as well. And maybe there was a question around, is there any good news? Is there, can you share? I love the fact that you're thinking upstream and we are going to partner. We already have a pathway for our partnership around, certainly with the School of Nursing, but certainly around research as well. And I'm wondering if you can share, is there good news around this work? Because it is about bending that curve. We're seeing it in our organization with the number of dialysis chairs, the number of people who come in with diabetes, and it's not, it is not lessening. And so we need to do something different. Our research and our institute is aiming to do that, to look at chronic illnesses. But from where you sit in academia, can you share where that hopeful sense is? Please.
Yeah, that's a great question. I do think that while this data is historically gone in one direction, and that's not necessarily the positive direction, I do think that there is substantive moves right now to look at lessening the amounts of processed foods that we have exposure to. I do think that there's policy makers that have the openness to look at some of those processed foods and to look at whether we should or should not be consuming them. Those types of changes take a long time. They take advocacy and they take work. I do think that our population has become much more aware. I've heard many times that sitting is the new smoking. And as we have seen with advocacy around the smoking movement, I know vaping is a different thing now, is bringing it all back. But the work that we did with smoking and smoking cessation has really made a huge difference. And I think when we look at the approach we took with smoking, we can apply many of the things that we learned there to our lifestyle, both in the workplace and certainly public sector workplaces like William Osler and Sheridan College can institute these much more readily, but we can do it on a holistic scale where we can give people the space and place to be healthy at work. And that message, if you go through strategic plans, I love what was written in the Osler plan, but certainly I've seen it before in our plan and other plans around giving people the opportunity to be healthy at work. The emphasis on mental health has become absolutely astronomical compared to just 5 years ago. So there are a number of things that are in sort of working its way through. We won't see them in the data yet, but they're coming. And so this is our work, certainly in this space, is a generation of all that positivity that's coming through. When it happens, when we start to see declines in obesity and increases in physical activity, I'll be just as excited as everyone else. Yeah,
sure. Okay, I'm just wondering if there are any questions in the audience. Because if there's not, then I will ask, there's a question online that says, explain a little bit more about how do factors like income, education, and employment status influence obesity prevalence?
Sure. So income, employment, I'll use employment for one, but they are related. So the higher up you are in the socioeconomic status provides you more space. For example, a single mom who has to work with their kids on their math and provide dinner and provide activities and does not have necessarily option or opportunity to get tutoring done while something else gets done. And that is a small example, but if you work that out over time, the space and place you have in terms of the amount of resources you have access to personally, you will be able to solve more issues and provide time for yourself to exercise. You'll also have access to private healthcare. So, going to see a physiotherapist, going to see a chiropractor. If you do not have benefits, that is a cost to you, and you may not be able to assume that cost, and therefore you might be living in an unhealthy state with a chronic back condition, et cetera, and that can affect your employment prospects. And so it can be a bit of a negative cycle that the lower you are on the socioeconomic status, the more difficult it is to purchase foods that are organic and to prepare those foods because those require time. And one of the new fads is you go to a company and you purchase the entire meal and they drop it off at your door with instructions on how to make it. Well, that's expensive. That's not as cheap as going to buy it yourself and having to prepare it yourself. And so the lost art of cooking, I would say, plays a role there, but also the space and place to do that cooking. If you are at home and you have the opportunity to do that, that's great. But if you're working a job and raising home and raising kids and attending to all the needs, it makes it much more difficult. And so when we look at the factors around education, the more educated you are, the more exposure you have to things like clinical research and data and the understanding of that and being able to decipher new research and what is and is not, quote unquote, fake news. Again, the socioeconomic status or the job that you may have may allow you space and place to buy or access better foods, better healthcare. And when we looked at the wheel around, what can be done, your own personal behaviors, well, buying better food is a personal behavior. Access to private healthcare, well, that was 10% of what can determine your health and wellness. And so access to those things obviously provide you an opportunity to attain better health and wellness over a longer period of time. Yeah.
Okay, I want to thank you for bringing this information to us and for sharing. Like I said, we are recording this so that we continue to build a library of resources for our staff. I think that this has been helpful for me too, when we start talking about our partnership and where is it that from an academic and practice perspective we can really bridge that gap. In terms of the partnership to really positively influence our community. We know what happened during COVID to our community, and that was exposed through the really difficult time we went through the pandemic. And I think it's galvanized us to really think about, as a healthcare institution and a pillar within the community, how can we partner with others to really seriously look at these issues in a different way, to create opportunities and platforms for our patients and families. And it's not as easy as, eat less, exercise more, we'll see you in 6 months. It really is getting into some of the deeper conversations, Michael, that you've been talking about, is really trying to better understand the person, their experience, and how do they actually, or if they can actually integrate that into their lives. So just want to thank you for providing us with a really thought-provoking discussion today. Thank you.